this is something that anticipates my last topic of today, which is the biggest problem we have today in implant and in perio. Proximity. This is our nightmare, yes? Proximity is our nightmare both when we treat gingival recession, when we treat bony defect, as we saw this morning. If there is no soft tissue at all, we have to extract one of the teeth, but also around the implants. So if there is proximity, this is the most challenging situation. And we cannot solve all cases in which there is proximity to be solved. Let's start with root coverage. You see, this is an incredible, difficult patient. And this is despite the level of attachment and the level of the bone is perfect, you know? It's not a matter of attachment level, the determining factor for achieving complete coverage or not is the proximity of the root. And when I speak about proximity, it's not only that the two root is too close, but you can see how much this soft tissue, this papilla, is palatally displaced with respect to the amount of avascular surface that you want to cover. And now that you have already done the first model, you should understand my words. Remember that we spoke about relationship or ratio between vascular surface, which is the area of the papilla, coronal to the cement enamel junction. How much vascular bed you have coronal to the cement enamel junction in this patient compared to the avascular surface that you have to cover. So this is a case in which there is no way to achieve complete coverage. There is no way because it's too unfavorable. The ratio between vascular bed, coronal to the cement enamel junction, and avascular surface to be covered. And then there is something that we can do surgically in order to optimize the outcome that can never be 100% of root coverage. This, for example, is another condition where the papilla is narrow, yes or not? But despite this papilla is narrow, you can see this papilla is located at the same buccal level, more or less, of the root. So in terms of blood supply, this papilla gives much, much more blood supply than this compared to the avascular surface that you have to cover. And this is something that you have to recognize because nobody tells you. If you look at the literature, they tell you that the only factor determining root coverage is the level of the attachment. And here the level of attachment is perfect. And so if you don't achieve complete coverage, you think maybe it's a fault of yours, which is not true. There is so many other factors, and especially the ratio between vascular and avascular surface that still is not fully understood as the main determining factor for achieving complete coverage. So what can you do in a case like this to, let's say, surgically compensate as much as possible the proximity between the root? This is the best. No, if you try to reduce this, you go to the pulp before there is a significant increase in the vascular bed, you know? So theoretically, the only thing that you can do is work orthodontically. But work orthodontically means that you obviously have to change completely the patient mouth in order or to extract one tooth. If you extract one premolar, this becomes perfectly coverable because this becomes an edentulous site, so the vascular compared to the avascular becomes favorable, but you have to extract one premolar. And most of the patients are not happy. So this is the maximum amount of coverage you can achieve in a case like this that if you look at carefully is not complete. Here there is the cement enamel junction that is exposed, and here there is the cement enamel junction that is exposed. But look now, this papilla, it seems to be another patient. So it's a great outcome which is not 100% coverage. But in order to do this, we need really very. So what can we do surgically? First of all, we have to use a trapezoidal approach with no doubt, because the only way for this papilla, for the papilla that we create between the two adjacent teeth, to advance coronally and take 100% of the blood supply coming from the anatomic disepithelize is if you use a flap that goes straight full. So no oblique incision, no multiple, no envelope type of flap. Otherwise, this papilla cannot take the advantage of receiving the greater amount of blood supply. So trapezoidal flap approach is mandatory. And obviously, you can work at the level of the two adjacent papilla as much as possible, making them even wider than the 3 millimeters. So the flap here remains very stable because there is a lot of blood supply. The flap remains stable, and this can help the stability of the flap also in the area of weakness. Where you make the horizontal incision should be in keratinized tissue. So you have to leave at least 2.5, 3 millimeters of keratinized tissue, but the more apical you can. Because the more apical you go, the wider becomes the horizontal incision. But you cannot go more apical than here, because otherwise there is no keratinized tissue in your papilla enough to be stabilized above the anatomic disepithelialized papilla. So work on this. Now elevate this papilla, trying to maintain as much as possible a good thickness during this papilla elevation, using a very small needle for the shape. But as soon as you are able to elevate the angle, use the thinnest blade you have in order to maintain this papilla so small, but very thin, of uniform thickness. So this is the papilla elevation in this particular case, which is an exception because of the very big avascular surface. Now, what you need is a flap that is so free to be advanced coronally, that this papilla is so free to join with the anatomic disepithelialized papilla without any tension. And this will be the last one, obviously, to be stabilized once the adjacent papilla already stabilized the flap in the coronal position. Now you have to remove the whole submucosal tissue like we do in the lower incisors, because in this patient we don't have to leave any muscles, any submucosal in the periosteal bed in order to provide the best verticalization of the flap to the periosteal bed. So like you are treating gingival recession in the lower incisors. So remove the whole muscle submucosal tissue from the periosteum, especially apical to this very weak papilla. Now, disepithelize this papilla the better you can. The invitation is done with a blade, and then you have to buy the right microsurgical scissors that allow you to complete the disepithelialization towards the tip. Despite this papilla is extremely small, you cannot leave remnants of epithelium that don't provide any blood supply to the surgical papilla of the flap. Vascular bed, yes? Now, when you fix the connective tissue graft at the level of this papilla, you cannot use the single interrupted suture. Since this papilla is so palatally displaced, if you make a single anchorage, the risk is that the graft goes too much coronal and you don't leave enough vascular bed for the surgical papilla of the coronary advanced flap. So you have to use the same suture technique that we use around implants, remember? So graft, full thickness perforation to the palatal aspect. So you use a 8 millimeter long needle, not 6. Take the suture from the palate, perforate the palatal aspect with the mattress suture. You have to see the needle getting out here at the base of this papilla, just a bit coronal to the graft, so you can close and leave this area completely untouched by the suture. So I perforate the palatal aspect. I have to see the needle getting out here just corner to the graft, and now close the surgical knot so you don't risk to displace your connective tissue graft too much coronally in this papilla that it's so weak, so palatally displaced that don't allows you to place the graft more coronal than this. And obviously, you have to block the graft at the base of this papilla by fixing the surgical knot onto the graft. And you see that despite the graft is very, very nicely applied to the root, there is still the vascular bed of the entire anatomic desepithelialized papilla that is available for the surgical papilla of the flap. Now, you have to close the vertical incision, you have to close the surgical papilla, and then the last one is a papilla closure that is not a sling. Why? Because if you sling, there is the tendency of the suture to go or mesial or distal, and this is a papilla that is too small to be slinged. So you have to make a single interrupted suture that makes the base of this papilla full thickness to the palatal aspect coming back and close. So we need the 11 millimeter long needle, full thickness perforation to the palatal aspect once the flap is already stabilized at the level of the two adjacent papilla. Take anchorage in the palatal aspect with a mattress suture, go back below the contact point or above the contact point and close. So this is a very, very site-specific compression of the surgical papilla above the anatomical papilla at the base with no risk that during the sling, this suture can be moved or mesial or distal. So you need a compressive suture in the middle. So there is something that you can do during the flap design, during the flap elevation, during the sequence of the suture in order to improve the coverage. But as I told you before, so stabilization of the graft, and this is the healing, which is very good. But if you look at carefully, not all the root is completely covered. Here there is about 1 millimeter of remaining gingival recession, and most probably there is 0.5 years. So when you judge this, it's not a complete coverage, but it's not a case that you can try to do something more, you know?
Now you achieve more vascularized proportions. So can you do it again later?
No.
Because now you have
this is a wider papilla.
right.
Yeah, the risk is that this papilla, I don't know how much it is fully attached to the root, you know, because this is a papilla that comes from the soft tissue gain due to the connective tissue graft. So in order to use this papilla like this, you have to be sure 100% that it's completely fully attached to the root. So I think this is the maximum you can do for the patient, and don't try to do anything else.
Okay. And would you do a different approach in suturing like you will do with implants when you attach, let's say you can't really attach anything to this papilla, would you attach it to the buccal flap?
No.
How you do with the implants?
No alternative. In some case, we have to find orthodontic solution. Orthodontic solution is something that can completely change the position of the root and the space between the teeth before the surgical procedure. This is something that we have already spoken also during the first module, and now you see that we have nice distal and mesial papilla, and the tooth is in the correct position, so we can make a traditional flap approach and achieve complete coverage. But look how much the space between the root was increased thanks to the repositioning of the root, change of the tilt of this root before the surgical procedure. Same story in regenerative therapy. We may have very, very similar condition, yes? In this condition, the two teeth is so close, but there is a soft tissue isthmus between the two roots. In these teeth, the distance between the root is exactly the same, but there is no soft tissue. So what is the difference between these two? This can be treated with the regenerative procedure. In this case, one of the teeth has to be extracted. So is the presence of some tissue even if small, even if thin, but that can be managed surgically, the key point for maintaining or extracting a tooth, even if radiographically this true defect is more or less the same. And the distance between the root is more or less the same. I can tell you that most probably this root is even closer than this, but here there is no soft tissue between the root. So there is no way to achieve periodontal regeneration. Here, there is a very, very thin, small, but intact soft tissue isthmus. That means that I can preserve this by making what? The palatal incision, remember? Because by making the palatal incision, even if this isthmus is very thin, the soft tissue healing depends on how long I can bevel the incision in the palatal aspect and is not in relation to the width of the isthmus that in this case is extremely small. So we have to make the palatal incision, shift the entire supracrestal soft tissue from the palatal to the buccal aspect. Despite it is extremely thin, we can preserve the integrity of this because it's intact. We can associate this with a corneally advanced flap like we have already seen in the first model, because the advancement of the flap here, it's important to advance also the papilla that is left connected to the buccal flap, and it is separated from the palatal flap with the palatal incision. The entire supracrestal soft tissue is elevated full thickness because it's intact. If there is no, the tooth has to be extracted. This is the other area where there was another defect between the two centrals. Deep and superficial incision to allow the advancement of the flap that allows also the advancement of the papilla. So mucogingival approach also in this case, deep and superficial incision. So you see that there is advancement of the papilla, cleaning of the defect, root planing, ADTA, amelogenesis always. Despite this defect in terms of regenerative potential is absolutely not favorable, but the healing of the bony defect depends on how much we can, let's say, cover and isolate the defect from the oral cavity, and does not depend almost anymore from the numbers of bony wall like it was thought in the past. Amelogenesis, graft application to work as a barrier to prevent papilla shrinkage and to provide a good barrier that compensate the lack of the buccal bone and the buccal aspect of the defect, and works as a very, very good stabilizer of the blood clot in the area where there is no buccal bone, because there is the complete absence of the buccal bone. And finally, we close everything in the palatal aspect with single interrupted suture that connect the bevel incision we need in the palate. So this is the single step of this surgery, the wall. Look at the healing. In the healing, there is not soft tissue shrinkage, but soft tissue improvement in corneal direction. Now we could cover the recession at the level of the distal aspect, and look at the papilla is even more corneal than the starting point. That it's something that is very, very, very unique of this technique. In only 6 months' time, you can see the complete remineralization of the defect. And this is still stable 10 years after the surgery. But if the radiograph is the same, so there is a defect which is not so good in terms of regeneration, but there is no soft tissue between the root, can we perform periodontal regeneration? Not at all. So one of the two teeth has to be extracted, because if we extract one of the teeth, we create an edentulous site. And with the edentulous site, we can do whatever we like. We saw today to increase the papilla, to make the bone heal at the level of the ancient tooth. So this is an indication. So the only way to solve root proximity in the presence of the bony defect when there is no supracrestal soft tissue anymore is to extract the tooth. Place a Maryland, reduce the Maryland, leave soft tissue maturation and hard tissue maturation for 6 months. You see that now we have a soft tissue, and the soft tissue, we know how to manage the soft tissue of the dental site. We have loss of the emergence profile, we have the loss of the papilla, and despite there is the horizontal bone loss, we can do the platform technique, as we saw with the buccal incision, split thickness elevation of the palatal flap, desepitalization of the platform. So to create a very good connective tissue bed for the anchorage of the connective tissue graft. Once the platform is completely desepitalized, we have to find a way to create a double layer of the connective tissue graft in the area where there is much more papilla loss that was mesial to the lateral, then distal to the central. And so we fold the graft, not completely like in the case I showed you this morning, but only half of this graft is folded. So we can create a double layer in the site where there is more papilla to increase, and a single layer in the site where there is less amount of papilla to be increased. And then we close everything by advancing the flap at the level of the adjacent papilla once they've been desepitalized, and close everything at the level of the palatal aspect. So this is the end of the platform technique. This is before, this is after. Enormous amount of soft tissue segmentation in apicocoronal. And look, buccal lingual. This is the temporary crown before being reduced, and look how much soft tissue was gained in the 6 months of healing after the platform. And so this is the condition of the papilla before and after. We gain 1 millimeter of papilla height above the papilla between the two central, and we gain 4 millimeters of papilla height at the level of the mesial papilla of the lateral incisor. So now the soft tissue is perfect. So we can plan our implant placement. The bone is obviously perfect because we wait so much. We can place our implant flapless. We can make the conditioning of the tissue. This is the patient before. This is after the soft tissue segmentation. This is the papilla before. This is after soft tissue segmentation and implant placement. This is the papilla that was completely missing before the platform technique. Now, same height, same color, same texture of the papilla mesial. Final restoration. Same height of the soft tissue, same height of the papilla. So when there is no way to make periodontal regeneration because the true root is so close, the only thing that we can do is to extract a tooth. And this is the before and after. And this is the long-term outcome. What about teeth and implants? When there is such a failure and there is no space between one implant, we are always touching the topic of proximity. How can we solve this proximity? We saw that there is some surgical solution. There is some solution which needs tooth extraction. In this case, the implant and the tooth is attached. But the implant, we can remove the crown. And the tooth, since we have a lot of extrusion of the two central, you see how much these teeth extrude, and this is very bad in the patient's smile. We have to sacrifice some of the central that needs to be covered with some veneering. So we gain space. How can gain space? Reducing the abutment as much as possible and making a sort of crestal preparation of the abutment, like bopped, if you want to call it. So the distance between the abutment and the adjacent natural abutment is increased so much that now we can gain soft tissue. Remember, the crown and the tooth was attached. Now we reduce the abutment of the implant, we reduce the abutment of the tooth during the preparation, so there is 1.5, more than 1 millimeter of soft tissue isthmus. And when there is 1 millimeter 0.5 of soft tissue isthmus, we can work surgically. You leave this isthmus to heal completely for at least 6 months. And now we can work surgically. Surgically means we can make submarginal incision at the level of the implant site to create a longer papilla. So submarginal incision at the abutment, submarginal incision at the abutment of the implant. This makes this papilla longer, and thanks to the advancement of the flap, this longer papilla can reach the palatal aspect and close everything by first intention, provided that the increase in the thickness of this papilla is guaranteed by the connective tissue graft. So connective tissue graft at the level of the implant to mask the transparency. Each of the connective tissue graft is extended at the base of the papilla to promote papilla growth, but now we have to cover. And how can we cover? We extend this epithelialization toward the palatal aspect, and we take the advantage of the increased length of the surgical papilla during the incision to make everything heal by first intention. So there is surgical, let's say, trip and tricks that allows you to overcome the problem of the proximity, provided we work prosthetically to create a space enough between the abutment or natural abutment and implant. So this is the healing of the soft tissue. This is the final restoration. 5 years follow-up. Look at the distal papilla, same height, same shape of the distal papilla of the natural tooth. And this is the comparison before and after. So there is also prosthetic means that helps us by preparing the abutment to increase the space and work surgically with the connective tissue graft in order to promote papilla growth.